Picture this. You are a nursing student on a med-surg floor. You have 4 patients, and within the span of about 6 minutes, all 4 of them need something at the same time. Room 2. 04 is calling the light. She's been asking for pain medication for 20 minutes, and she is not happy about it. Room 206 just had a blood pressure of 88/54 on his last vitals, and the tech is looking at you like, so, what do we do? Room 207's family member stops you in the hallway and says her mom seems more confused than usual, which you're not sure if that's new or just her baseline, because you just got this patient this morning. And room 209 is a post-op day 1 who is due for a dressing change, and you have not even laid eyes on her yet today. 4 patients, 4 things, right now, all at the same time. And you are standing at the nurse's station, and I want you to really feel this. You are standing there and your brain has completely frozen. Not because you don't care, not because you're not trying, not because you don't know what to do individually with any one of these patients, but because you are trying to hold all 4 of them in your head simultaneously. Figure out who goes first. Justify that choice in case someone asks you. Execute the right intervention for the right patient and not let anyone fall through the cracks. All at the same time. That is not a knowledge problem. That is a prioritization problem. And it is one of the most common things that breaks nursing students and new nurses in clinical. So what do you do? And more importantly, how do you build the kind of thinking that makes that decision fast, confident, and correct? Not because you memorized a list, but because you understand the mechanism behind how providers actually decide who goes first. That is exactly what we are covering today. Let's get into it. Welcome to Think Like a Provider. I'm Professor Genoway, nurse practitioner and creator of Think Like a Provider, the clinical reasoning system that teaches nurses and nursing students to master body systems through pathophysiology and evidence-based frameworks. We don't memorize here, we understand. If you're new, every episode we break down the mechanisms behind clinical reasoning, neuroscience, and what it actually takes to perform at your best, so you walk away thinking and acting like the provider you are meant to be. And if you want to go deeper than a podcast can take you, we will have the Think Like a Provider Academy on School. Courses, a question bank, and a community of students who are done memorizing and ready to actually understand. The waiting list link is always in the show notes. Now, let's get into it. Today, we are in the core clinical reasoning lane. This is the meat, the mechanism, the stuff that actually changes how you think at the bedside. And I chose this topic specifically because of how often I see students get this wrong. Not because they're bad nurses or bad students, but because the way prioritization is typically taught sets you up to fail the moment real life gets complicated. We are going to fix that today, mechanistically. The problem with how we teach prioritization. Let me tell you what nursing students are usually taught about prioritization. You're taught the ABCs, airway, breathing, circulation. You're taught Maslow's hierarchy of needs. Physiological needs first, then safety, then everything else. You're taught to handle the patient who is most unstable first. And you're taught that in the NCLEX world, the patient with the most acute physiological threat takes priority. And here's the thing, none of that is wrong. All of that is correct. The problem is that it's taught as a checklist, as a rule to memorize, as a formula to apply. And then you get to clinical, where nothing fits the formula cleanly and you freeze. Because here's what the textbook doesn't tell you. Real prioritization is not a ranking exercise. It's a pattern recognition exercise. It's not which patient is sickest. It's which patient is most likely to deteriorate most quickly if I don't intervene right now. And that distinction matters enormously. Think about it this way. A patient with a blood pressure of 88/54 who is post-op day 2, asymptomatic, has a known baseline of running low and looks comfortable and alert. That is not the same priority as a patient with a blood pressure of 88/54 who is diaphoretic, confused, tachycardic, and was fine 2 hours ago. Same number, completely different clinical picture, completely different priority level. But if you were taught low BP equals priority, you don't have the tools to make that distinction. You have the number, you don't have the mechanism, and without the mechanism, you're guessing. This is the core problem. Prioritization taught as rules and rankings produces nurses who can answer NCLEX questions about prioritization, but freeze in real clinical situations because real life doesn't give you clean textbook presentations. Real life gives you 4 messy patients at 9 a.m. and a charge nurse who is also managing her own assignment. So let me give you the mechanism, because once you understand why prioritization works the way it does, you will never have to memorize a rule again. The mechanism behind prioritization. At its core, clinical prioritization is about one thing: physiological stability, not urgency, not acuity, not who is loudest or whose family is most concerned. Physiological stability. Is this patient's body currently maintaining the conditions necessary to sustain organ perfusion and cellular function? Or is that ability compromised? And if so, how quickly and how reversibly? Let me break that down. Your body has compensatory mechanisms. We talked about this back in episode 2, the compensation-decompensation arc. Your body does not go from fine to crisis in one step. There are stages, there are signs, and your job as the nurse is to recognize where a patient is on that arc. Because the further along they are toward decompensation, the less time you have and the higher the priority. So the real question when you're prioritizing is not who needs something. Everyone needs something. That's why they're in the hospital. The real question is, which patient's physiological compensatory mechanisms are currently failing or at risk of failing, and what is the timeline? Let me give you a framework, and I want to be very clear. This is not a list to memorize. This is a way of thinking that you apply systematically. The first question, is this patient's airway, breathing, or circulation immediately compromised? Not potentially compromised, not trending toward compromise, immediately, right now, compromised. If the answer is yes, that patient is your first priority, full stop. Because without a patent airway, adequate ventilation, and adequate perfusion, nothing else matters. No other intervention has any effect if the patient cannot oxygenate their tissues. This is where the ABCs actually live, not as a checklist to recite, but as the physiological foundation that everything else depends on. Airway is first not because someone decided it should be first, but because oxygenation is the rate-limiting step for cellular survival. You can have a broken leg and survive. You cannot survive 4 minutes without oxygen to your brain. The second question, is this patient actively decompensating? Meaning, are their compensatory mechanisms working but failing? This is the subtler one. And this is where pattern recognition from episode 7 becomes critical. A patient who is tachycardic, short of breath, and hypotensive, that patient's body is telling you something. The tachycardia is compensation. The shortness of breath is compensation. The hypotension means the compensation is losing. That patient may look okay-ish compared to someone in full arrest, but they are on the clock. They are in the window where intervention can change the trajectory. That window closes, and once it closes, you are no longer preventing decompensation. You are responding to it, which is a very different and much harder situation. So active decompensation, even if the patient still appears relatively stable, is high priority, higher than a patient who is uncomfortable or waiting or unhappy, but physiologically stable. The third question, is this a new problem or an established one? New acute changes in a patient's status take priority over chronic known issues, even if the chronic issue looks more dramatic. A patient with chronic obstructive pulmonary disease who is always somewhat short of breath and is sitting at their baseline is different from a patient who has never had respiratory problems but is suddenly working to breathe. The COPD patient's body has adapted. The previously healthy patient's body has not. New is almost always higher priority than known and chronic, unless the chronic condition is actively decompensating. The fourth question, what is the trajectory? Is this patient getting better, holding steady, or getting worse? And how fast? A patient trending downward, even if they are not in crisis right now, demands your attention before a patient who has been sitting stable for 3 hours, because trajectory tells you where you're going. And getting there before the destination is always better than arriving after. Those 4 questions, immediate compromise, active decompensation, new versus established, and trajectory, those are the mechanism behind every prioritization decision you will ever make. Not a ranking, not a checklist, a way of thinking that you apply to every patient on every shift. Back to the 4 patients. Let me walk you back to the 4 patients from the beginning, because now you have the mechanism, and I want to show you how this actually works in real time. Room 204 is calling the light. Pain medication, been waiting 20 minutes, not happy. Room 206, blood pressure 88/54. Room 207, family says mom seems more confused than usual, unclear if that's new. Room 209, post-op day 1, haven't seen her yet, dressing change due. Let's run the 4 questions. Room 206 first, blood pressure 88/54. Immediate compromise, active decompensation, or trajectory concern. You don't know yet, which means this patient needs eyes on them right now. Not because the number alone makes them the priority, because you cannot answer any of the 4 questions without actually assessing them. A number on a vital sign monitor is not a clinical picture. You need to walk in that room, look at that patient, and assess. Are they diaphoretic, tachycardic, confused, pale, breathing comfortably, or working hard? That assessment takes you 60 seconds. And what you find tells you whether this is a call the provider now situation or a watch closely and recheck situation. Go there first. Room 207 next. Confusion, new versus established. You don't know the baseline yet because you just got this patient. That matters. Acute confusion, new onset altered mental status, is one of the most significant clinical flags you can encounter because it tells you that something is affecting brain perfusion or brain function. That could be hypoxia, hypoglycemia, sepsis, stroke, medication effect, fluid imbalance, or a dozen other things. And because the brain is exquisitely sensitive to physiological compromise, new confusion is often your earliest warning that something systemic is going wrong. Before you get deep into your other tasks, you need to get a baseline on this patient. Talk to her, assess her orientation, check her vitals, look at her recent labs. This does not take long, but it cannot wait until you're done with everything else. Room 209, post-op day 1. You haven't laid eyes on her yet today. Dressing change due. Now, a dressing change itself is not a high acuity task, but a post-operative patient you haven't assessed yet. That requires a look. Not an emergency look, but I need to know this patient is stable before I move on. Type of look. Quick assessment. Check her vitals. See how she looks. Then the dressing change can happen in an organized way once you've confirmed she's doing well. Room 204. Pain. Waiting 20 minutes. I know. She's frustrated. You feel bad. But pain, in the absence of physiological instability, is not the same priority as the patients above. Pain is real. Pain matters. Pain is your priority, but not before you've verified that nobody else is actively decompensating. The moment you've assessed 206 and 207 and know they're stable, 204 is next. And you communicate that. You go in, you acknowledge her. You say, I hear you, I'm coming right back. And you mean it. You don't disappear. But you don't let guilt about a frustrated patient pull you to their room while another patient's blood pressure is sitting at 88/54 unassessed. That is prioritization done by mechanism, not by the number, not by who called loudest, by physiological stability, decompensation risk, new versus established, and trajectory. The mistakes that break new nurses. Now, let me name the traps because knowing the framework is one thing, and recognizing when you're being pulled away from it is another. The loudest patient is not always the highest priority. I cannot say this enough. Patients who complain loudly, whose families are vocal, who have been waiting and are angry, they pull your attention through social pressure, not clinical urgency. And if you let social pressure drive your prioritization, you will consistently underattend to the quiet patients who are not complaining because they are too sick or too altered to advocate for themselves. The sickest patients are often the quietest. The patients actively compensating for significant physiological compromise frequently do not feel well enough to call the light. You have to go find them. Task completion is not patient care. New nurses, especially, fall into this one. You have a mental list of tasks, medications due, dressing changes, assessments, documentation, and the tendency is to work through the list in order, checking things off because it feels productive and organized. But tasks do not prioritize themselves by clinical urgency. The dressing change that is due at 9 a.m. does not know that your patient in room 206 has a blood pressure of 88/54. Your list does not reorganize based on what's happening. You have to. And that requires constant reassessment throughout the shift. Not just a prioritization decision at the start of the day, but a running dynamic process of reading your patients and adjusting. Confirmation bias will get you. We talked about pattern recognition in episode 7, and here's where it can work against you. If a patient has a known history of hypotension, or a known history of anxiety, or a known baseline of confusion, it is dangerously easy to attribute new changes to the known pattern and miss that something new is happening. The patient who always runs low can still go septic. The patient who always seems anxious can still be having a pulmonary embolism. The patient who has some baseline confusion can still be having a stroke. Known history explains a pattern. It does not guarantee the current presentation is the same pattern. Always ask, is this their normal, or is this normal plus something new? Doing something is not the same as doing the right thing first. When you're stressed and overwhelmed, the temptation is to just move, to do anything so you feel like you're making progress. And often what you pick to do is whatever is easiest or fastest or most familiar. The dressing change over the blood pressure assessment, because you know how to do a dressing change, and the hypotension scares you. The medication administration over the new confusion because the med is on your MAR, and the confusion is ambiguous. Anxiety makes you gravitate toward the concrete and the familiar. Prioritization requires you to stay with the ambiguous and the uncomfortable long enough to assess it properly. The prioritization mindset shift. Here's what I want you to understand at a deeper level. The goal of clinical prioritization is not to be efficient. The goal is to prevent failure to rescue. Failure to rescue is a specific term in nursing and patient safety literature. It refers to the failure to identify and respond to a patient's deterioration in time, to prevent a bad outcome, and it is one of the most significant drivers of preventable harm in hospital settings. Patients do not usually go from stable to crisis instantaneously. There is almost always a window, a period of early deterioration where the trajectory is clear if you're looking for it, and where intervention can change the outcome. Failure to rescue happens in that window, when the signs are present but they're not recognized, or they're recognized but not acted on quickly enough. Your prioritization decisions are your mechanism for staying inside that window for every patient you're responsible for. Every time you walk into a room and do an assessment, you are checking, where is this person on the stability arc? Are they where I expected them to be? Are they better, the same, or worse than the last time I looked? Because that trajectory is your early warning system. This is why the see your patients piece of nursing is not optional and not just procedural. It is your surveillance mechanism. It is how you catch the patient who is quietly decompensating before they announce it with a code. And your ability to prioritize correctly, to see the right patient at the right time, is what makes that surveillance effective. This is not about being the fastest nurse or the most organized nurse. It is about having a framework that ensures the patients who are most at risk of deteriorating are in your line of sight most often, and that your interventions are sequenced around physiological urgency rather than task convenience or social pressure. Practical application, building the skill. Let me give you the concrete application, because we are mechanisms over memorization here, and mechanisms have to translate into practice. At the start of every shift, before you do anything else, get a basic read on every patient, not a full head to toe, a 30-second visual assessment. Is this person awake and alert? Are they breathing comfortably? Do they look how I expect them to look based on handoff? This is your baseline. Everything you observe for the rest of the shift is measured against this baseline. You cannot recognize deterioration if you don't know where the patient started. Use the 4 questions as a running filter. Every time a new piece of information comes in, a vital sign, a patient call, a family concern, a lab result, run it through the 4 questions before you decide what to do with it. Immediate compromise, active decompensation, new versus established, trajectory. Those 4 questions take approximately 10 seconds to run through your head. They will reorder your priorities faster and more accurately than any task list. Communicate your prioritization. When you can't get to someone immediately, say so to them and to the team. I'm going to check on room 206 right now. I'll be back to you in 10 minutes. I'm flagging room 207 for the charge nurse because the family is reporting new confusion and I want another set of eyes. You are not working in isolation. Your team is a resource. Your charge nurse exists for exactly the moments when you have competing priorities and you need backup. Use them. Practice uncertainty tolerance. One of the hardest parts of clinical prioritization for new nurses is making a decision when you're not 100% sure. Because you never are 100% sure. You're working with incomplete information, under time pressure, with multiple competing demands. The goal is not certainty. It's a defensible decision based on the best available information, executed quickly enough to matter. If room 206's blood pressure scares you, you don't have to know exactly why it's low before you go assess them. You go assess them and then you figure out why. Assessment first, diagnosis second. Here's where I want to leave you. Prioritization is a skill, and like every skill in clinical practice, it gets better with deliberate practice, which means it gets better when you practice it consciously, with a framework, rather than just reacting and hoping you guessed right. The 4 questions: immediate compromise, active decompensation, new versus established, and trajectory. Those are your framework. Not a list to memorize for the NCLEX, though they will absolutely help you there too. A way of thinking that you apply every single shift, with every single patient, every single time something changes. The goal is to build the kind of thinking that becomes automatic, where you're no longer consciously running through the questions, because the framework has become part of how you see patients. That is exactly what episode 7 was about, how pattern recognition develops. This is the same process. You're not trying to memorize prioritization rules. You're building a prioritization schema, a mental model that recognizes the clinical picture and generates the right response. Faster and more reliably over time. You will make mistakes. Every nurse does. The shift where you spent too long with the frustrated patient while someone quieter was deteriorating. The day where the new confusion turned out to be medication effect and not a stroke, but you escalated anyway. And that was the right call because you had no way of knowing yet. Those experiences are not failures. They are the curriculum. Every prioritization decision you make, right or wrong, is building the schema. It is building the pattern library. It is making you faster and better at this. What I need you to stop doing is treating prioritization like a list and start treating it like a living, dynamic clinical judgment that you are actively making and revising in real time. Every single shift. That is what it means to think like a provider. For this week's homework, and you knew it was coming, I want you to pick one shift, one clinical day, and consciously run the 4 questions at the start of every patient interaction. Not at the start of the shift only. Every time you get new information, vital signs, family concern, patient complaint, lab result, before you decide what to do with it, run the 4 questions. Notice what it changes. Notice the moments where the questions redirect your attention somewhere you wouldn't have gone otherwise. That's the skill building in real time. If you want to keep building this, if you want a community where this level of thinking is the baseline, where you're not the only one who takes clinical reasoning this seriously, join the Think Like a Provider Facebook group and the Think Like a Provider Academy School waiting list. The link is in the show notes. You cannot prioritize what you do not understand. Learn the mechanism. Trust the framework. Your patients are counting on it. I'll see you next week.